Sudah sampai ya. Selamat Hari Merdeka.
Ya, terima kasih, terima kasih.
Terima kasih.
Oh, how's everything in Malaysia? Getting better, huh? Regarding COVID?
So-so lah.
So,
Boleh lah tahan.
Still ada case, eh?
Yeah, we are still worried about second wave and so on. So we are a bit cautious. A lot of students coming back from other countries and so on. Tapi kan kita ada community spread pun started.
Oh.
So I have to be a bit more cautious. How's everything in Indonesia, in Jakarta?
Jakarta still 500 minimal per day.
Okay.
Yeah,
it will come down.
Yeah, because they have more and more tests now available. So the government, very aggressive doing tests now. So that's why. So I don't know about the other province. So I'm a bit more worried about the other province because look like the case is small, but I don't know whether the test number is good enough or not. I don't know. In Bengkulu there is gimana Mir? Bengkulu Mir?
So-so lah dok.
So.
I think it'll be like New York. First New York was a lot, then after that the rest was less. Now New York sudah turun, the Florida everything went up, Arizona.
New York turun New York decline actually.
Decline. New York now is quite low already, one of the lowest.
Really? Yeah, no Florida,
Florida is coming down, but Arizona, certain other places going to go up, I think.
Oh, Arizona, yeah.
Kwan, tempat Dr. Kwan.
Yeah, because the middle belt, because they pro-Trump area.
Hari ni cuti kan? Today is holiday, right?
Yalah.
Rajin.
Untuk Asri lah.
Rajin sangatnya. Rajin bangetnya.
Asri, I miss you. Just coming lah to Jakarta.
I will try.
Bosan. Webinar.
Yes. Hopefully lah.
So,
how's everything in harapan kita?
Yeah, the case getting increased again. Getting let's say 70 to 80% normal lah.
Right.
Because everybody tak bisa tahan lah. Chest pain something like that. So we must they keep coming now.
And your new blog is going up.
Oh, you know already.
Cantik ya.
Astri, Jabat Ministry of MOH Malaysia.
Spy. Spy ramai.
Spy. So is Dr. Nagamatsu is already here? Oh, not yet,
Not yet, Dok.
Yeah?
Not yet.
Dr. Arwin, apa khabar Dr. Arwin? Okay.
Hai Dr. Asri, alhamdulillah kabar baik. Terima kasih.
Dr. Ismail nampak handsome pakai batik ya.
Ya, everybody pakai batik lah, Asri.
Saya cat lab.
Oh, you cat lab ya? Ya. Oh, yeah, working day, I forget. I'm still thinking this is Sunday, Not weekend. Okay. So Sri, there will be national anthem for 1 minute and something like that, and then biasalah ya.
Sure.
Speech ya. You want to deliver a speech, Sri, regarding our?
Dah nampak Dr. Nahar?
Ada Dr. Nahar.
Hello,
Jogja.
Good evening.
Apa kabar ya Dr. Nahar?
Halo, Dr. Asri.
Jogja sihat?
Halo.
Halo.
Sehat tak kata dia, Dr. Asri? Alhamdulillah sehat.
Alhamdulillah.
Sri, dah pernah ke Jogja, Sri? Have you ever been to Jogja?
Belum pernah.
Should go lah.
Selalu
si Borobudur Temple.
Ya. Plan. Selalu pergi Bali aja.
Please come to Jogja.
Next time.
Dr. Asri, next time.
Actually, this event should be in Jogja, Sri.
I see.
Yeah, my sensor event today should be in Jogja. We already prepared with Dr. Nahar, so everybody will come to Jogja, and then Okay, and then there will be afternoon dinner in Borobudur. So it's already settled up.
Not
Ask the
Borobudur.
sensors. It's already settled up. And then
Not Borobudur, Prambanan, Dr. Doni.
Prambanan, ya sorry, Prambanan.
Ya.
Prambanan.
Oh, apa tuh? Wow.
Dok, dimulai saja dok. Udah tinggal 10 menit lagi dok.
Ya.
Enggak, saya kira sih, everybody is already here. I think you know about this. I will start with the national anthem. Ini kan langsung aja San ya, direct to national anthem. Ya San?
Iya, iya dokter.
Iya dok.
Jadi direct to national anthem and then say greeting to all the faculties. And then there will be Dr. Nagamatsu will present the slide for 15 minutes. And then direct to Dr. Asri another 15 minutes. And then 10 minutes discussion. And then after that, there will be 2 cases from Dr. Arwin and Dr. Larasati, Dr. Ati. So I think everybody welcome if you want to have some comment or something. And then we hope we can conclude around 5:25 p.m. 5:25 p.m. So I think it's ada Asri, you already try your slide?
Belum lagi ya.
Silakan.
I try ya.
Ya.
Nampak ya.
Ya. Asri Rangga has started sharing. Cantik.
Selalu kissing aja kita orang.
Big hospital.
Yeah. Asri ini expert dalam kissing.
Boleh lah. Okay, I think should be okay. Tak ada video.
Should be okay. Okay. Yeah, it's very clear. Yeah, nice pictures.
Thank you. Okay, sudah.
Okay, no problem. So Dr. Nagamatsu is already here or not? Because I don't see his name on my
Belum
monitor.
juga dok.
Halo.
Dari kanekanya lagi coba tektokan masih.
Okay, if Dr. Nagamatsu still not here during the meeting, so Asri will be the first. Yeah, it's okay, Asri.
Okay, no problem.
Okay.
Maaf, Dokter Dian bisa di-share screen, Dok? Dicoba, Dok. Dokter belum.
Iya. Semuanya share. Ya, Dr. Dian, Terati, tolong share screen. Rehearsal. Bisa di rehearsal, Ti. Share screen. Share screen-nya, Ti?
Share screen. Oh, oke.
Belum. Ya, rehearsal.
Sekalian bicara,
Akhirnya.
kita tes suaranya, Dok.
Tes suara, baik, Dok.
Oke.
Kurang keras, Dokter.
Share
Kurang
screen
keras.
kelihatan, Dok?
Ya, bagus banget.
Jelas.
Bagus, jelas.
Jelas, ya.
Tapi sound-nya Ati kok agak pecah, Ti, ya?
Pecah ya, Dok? Waduh.
Enggak sih, maksud saya Ti agak kurang begitu ini ya, bulat gitu.
Oh, sebentar, Dok.
Oh ya, tapi yang terakhir agak lumayan.
Balik.
Oh gitu. Oke, good. Oke, dan Dr. Arwin mungkin ya, Ati bisa close apa?
Oke, Dok.
Ya.
Ini better, Dok. Suaranya gini. Masih pecah?
Pecah lagi, Ti. Pecah. Sekarang malah pecah. Tadi malah lebih lumayan.
Ini selesai, Dok.
Oke. Oh iya, Arwin oke lah ya. Oke, good.
Biasa, Dok. Oke, Dok.
Oke, good. Oke. Ati coba ngomong lagi, Ti.
Saya cari earphone lain lagi deh, Dok,
ini.
sebentar ya. Ini better.
Oh iya, better tapi terakhir pecah sedikit aja.
Tapi
sebenarnya bisa didengar sih, tapi ya.
Jelas kok.
Wah,
Jelas ya.
Selalu.
Mungkin speakernya Dokter Doni terlalu bagus.
Jogja, emang orang Solo tuh ke Jogja memang kayaknya sih.
Aduh, sampai
orang
jatuh.
Solo kayaknya.
Jatuh.
Sore Dokter Asri, apa kabar?
Apa kabar ya, Dr. Dian?
Saya waktu kemarin sempat ke Serdang, Dok. If you still remember.
Yes, of course. I know you're a very good-looking father.
Ya, thank you, Dok.
Oke, apa lagi kira-kira yang ini Dokter Dari NKN kira-kira Pak Indra ada yang mau di ini lagi?
Cara pertama, Dok.
Oh ya, itu belum muncul nih.
Ya.
So from Vice Chancellor or from Kaneka is Dr. from Japan is already here. Dr. Nagamatsu.
Masih belum, Dok.
Because he's already was with us during rehearsal.
Mereka minta
3 days
Dokter
ago.
Asri dulu, Dok, yang pertama, Dok.
Oh,
Karena masih coba hubungi ke Dokter Nagamatsu.
wow. Oke lah, no problem lah Sri ya.
Boleh aja ya.
Okay. Usually we stop 10 minutes before 4 p.m. Yeah, just for everything, and then we will come back 4 p.m. straight.
Okay.
And then after that, this is Dr.
Dr.
Nagamatsu. Halo, Dr. Nagamatsu.
Good afternoon.
Halo,
Yeah, good afternoon.
Nagamatsu.
Okay, nice to see you. Good to see you.
Nice to see you. So I'm so sorry that I'm very late.
No problem. So you can test your slide. You can share
Yes.
screen. So, yeah, I want to see your slide.
I'm here.
Yes,
Okay.
you already. I mean, yeah, I can hear you
Yeah.
clearly. And then I want to see your slide.
Okay. Just a moment.
No problem.
Gue nggak yakin ini dia dong.
Can you see my slide?
Oh yes.
Okay.
All right. Okay, that's good. So we all set.
Yeah. So I would like to start the presentation.
All right. So can you? Do you have a video?
Yes. Just a moment.
Okay.
I would like to move the video slide. This
Right.
one.
Please. Okay.
Can you see?
Yes.
Yes. All
Yes.
right.
It's moving.
Okay.
Thank you.
Okay, that's good.
Yeah.
All right. So I think it's everybody set up. So Pak Rindra, kita close dulu atau gimana?
Oke.
Oke, Win, biasa kita kan close dulu ya?
Ya dok, kita boleh rehat dulu sebentar, mau ke kamar kecil.
Okay, I think 10 minutes before that, and then right here we stop all the screening. We close down for 10 minutes, and then after 10 minutes, the operator will make it alive again.
Okay.
But please don't leave.
Don't leave. Just mute and stop the video.
Okay.
Get and pause the video.
Dok, sekedar mengingatkan dok, kita mulai tepat ya dok ya, jam 4.00. Nanti untuk video tracer, hari ini kita ganti dengan Indonesia Raya. Jadi setelah 4 detik sebelum Indonesia Raya selesai, baru saya akan send dokter untuk menyalakan audio dan video ya dok.
Iya, terima kasih.
Oke dokter, terima kasih dokter. Yang ada tulisannya Kaneka sama biosensor itu turunin semua jadi panelis, jadi peserta ya, jangan keliru ya. Yang itu biosensor itu ada tulisannya biosensor kan.
Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, sejawat sekalian, dan juga tentunya bangsa dan setanah air. Pada sore yang berbahagia ini, kita kembali berkumpul dalam acara ISIC Distance Learning. Tetapi tentunya ini hari yang istimewa, karena pada hari ini kita merayakan Hari Kemerdekaan Negara Republik Indonesia yang kita cintai, yang ke-75. Untuk itu, marilah kita mengucapkan syukur alhamdulillah bahwa kita sudah bisa sampai ke-75. Sejawat kalian, baik. Mulai dengan mengucapkan kalimat merdeka, merdeka, merdeka. Mari kita berdoa semoga Allah Subhanahu wa taala memberikan rahmat dan hidayah sehingga kita bisa mengalahkan pandemi pada masa yang berat ini, dan kita juga bisa lebih memperkuat dan terutama dalam bidang intervensi. So selanjutnya saya akan berbicara dalam bahasa Inggris karena kita dihadiri oleh dua fakulti dari luar negeri. So first of all, I'd like to say thank you for all panelists for attending our distance learning in ISIC. So again, this is chapter number 34. So we a little bit busy since the first month of pandemic. So I will already talk to my colleague Nisha that this is a special day for us. That today is our Independence Day, August 17th. We proclaimed our independence in August 17, 1945. So in this event this afternoon, we have 4 faculties. The first one will be Dr. Wataru Nagamatsu, MD. Thank you for Dr. Nagamatsu for attending our meeting. Now he's working in the Hokusetsu General Hospital, and then active in Japanese Circulatory Society and also in Japanese Society of Internal Medicine. And then we also have, can I have a second slide for Dr. Nagamatsu? Nice to meet you. Nice to see you. Okay, no problem. And then second will be Dr. Asri Ranga. Dr. Asri, a good old friend of us, and then he attended EasyCamp so many times. Thank you, Asri, for attending our meeting this afternoon. And then we have also 2 case presentators. The first one, Dr. Arwin Mangkuano, and Dr. Dian Larasati. Dr. Arwin works with me in Hamburg National Cardiac Center, and Dr. Dian Larasati Munawar, or Dr. Ati, now working in Bina Waluya Hospital in East Jakarta. So we also have 2 panelists. One is Dr. Nahar Taufik, Senior Interventional Cardiologist from Sarjito, Yogyakarta, and Dr. Ismir Fahri from Bengkulu, Sumatra. Welcome for all of you to attending our meeting. Thank you very much. And also, I would like to say thank you as well to Biosensors and also to Kaneka to sponsoring our meeting today. So hopefully that we will learn many things this afternoon. I believe that we have a very nice discussion, and then I believe also there will be new learning points in this afternoon. So let's move to our first speaker, Dr. Wataru Nagamatsu. Dr. Nagamatsu will talk about basics to advance of using Crusade. So there will be 15 minutes talk. So Dr. Nagamatsu, please.
Thank you very much. Very nice to introduce. I deeply appreciate the invitation. Thank you very much. And I would share my slide. Can you see my slide?
Yes, yes.
Okay, thank you. Okay, and my talk is basics to advance of the using Crusade. And I will show the introduction for this lecture is two parts. And one is the function of the Crusade, another one is technique of the Crusade. And first of all, I would like to show the structure of the Crusade. Very famous tool, this one. Okay, and please look at this picture. This is a fluor picture. So this Crusade have the two metal markers. And please look at this one. This picture is showing the detail of the tip. And from the tip, the about 5mm more projection part and the exit of the by the wire lumen are there. The function of the Crusade is maybe there summarize the three parts. And one is the delivery of the big angle curve wire. And the second one is that we can deliver the second guide wire via a first wire loop. Last one is a backup. And especially the Crusade specification, I would like to explain about this. Over the wire lumen structure is a double layer and not double tube. And due to this double tube, and we can get the good backup force and avoiding the kinking. And I show the technique of Crusade, and using the Crusade, we can perform the many techniques. And I would like to explain about the more detail using the another slide. First, is the tips of the side branch access. This technique is a very popular one. And maybe that you know, so I would like to say it there about the tips. And I will give the three tips. One is a wire curve. And please make a big wire curve. And this, please look at the same picture. This R mean the diameter of the bezel. And plus 1 to 1.5mm. Please make a more bigger curve. And please making the care about the position of the Crusade. And maybe we have to do the try and error for the insertion of this guide wire. And please do the exploring from the distal side for the keeping the big curve. The second technique is the benefits of the stand cross using Crusades. And this one is another very popular technique and using the Crusade. And the benefits is three issues there. And one is keeping inner stand root and like that. Please look at this picture. And if this dotted line get advanced to the second guide wire, maybe very easy to occur the stand fracture. And after that, open the balloon at the side branch. And the benefit is keeping in a stand root using the Crusade. And another one is the delivery of the big angle curve. And last one is the back force for insertion via stand slot. And I show the actual case, and I performed stand leg loss to the circumflex. And so already this lesion is implanted the stent from the left main trunk to the LAD. And this circumflex guide wire is a protection guide wire. And so in this time, and we try to insertion the additional guide wire to the circumflex via stand slot. The steps, I will show the steps the standardly cross. And the first step is before insertion of the second guide wire and deliver Crusade to distal part of the bifurcation like that. And this is the key point for the deliver the big curve guide wire and beyond the bifurcation. The second step is the guide wire shaping. Please make a shaping the big angle and diameter, bezel diameter plus 1.1 to 1.5mm. And after that, and pull back the Crusade and with keeping guide wire position. This is a very important procedure. And pull back the guide wire and the insertion via stand slot. The third technique is a crusade stand boost. And due to the crusade 2 markers, I already explained about the crusade structure. And actually, this crusade have the 2 markers. And due to the 2 markers, we can perform a stand boost. The benefits in performing the crusade stand boost is the confirming guide wire position at the stand strut. And fourth technique is a reverse wire, a little bit an advanced technique. And so maybe you know, but I would like to summarize the steps. Please look at this schema. The steps in the first is a deliver for the guide wire to the coronary vessel and pull back the crusade like that. Pull back the crusade and with keeping guide wire position. And after that, pull back for the guide wire and maybe the automatically get advanced this second guide wire to the side branch. And after that, take out the crusade and they're exchanging the folded guide wire to the new guide wire using a single aluminum microcatheter. And how to do the preparation of the reverse guide wire and the steps. I show the steps. Please look at this figure. One is please prepare the polymer jacket guide wire, and I prefer to use a Sion black guide wire. And the reason why is the polymer jacket have the good lubricity. The second step is making folding part, and from the tip, the length is 2.224 centimeter. And set up the second guide wire out of the guiding and the insertion into the Y connector. This is the preparation of the reverse guide wire. But we have another option for the preparation. How to do that? The using side branch, and we call the streamline reverse wire technique. Already published this technique via the CCI. And please look at this picture. This is a LED region, and this dotted line vessel is a diagonal branch. This is the M branch, and this branch is a septal branch. The first step, the insertion to the bended guide wire to the septal. And after that, and please push this crusade microcatheter, and automatically, and we can make the reverse bent guide wire in the coronary. And when we perform the reverse guide wire technique, we have to think about the guide wire shape. The sharp versus round shape. Please look at this schema. And the upper line that I show the sharp curve. The sharp curve is like that. But on the other hand, round curve is like that. That this part looks like round. And what is the benefit of the sharp curve is superior in system delivery. It's very easy to deliver due to this shape curve and compare with round curve. But on the other hand, if the sharp curve is already bended, and after that we perform the reverse guide wire, and yes, and we have to change to the new guide wire. But sometimes very difficult to get advanced to the microcatheter additionally. But on the other hand, we use the round curve, very easy to deliver this additional microcatheter like that. And we have to think about the shape curve or the round curve, which is better. I usually try to using round curve at first. And if it's very difficult to deliver, I would like change to the shape curve. This is my method. I showed how about the guiding and guiding size and guiding shape and the success rate. This is one of the good paper and for the crusade reverse wire technique. Please look at this one. And so from this paper, and 7 French, the ratio is very higher compared with the 6 French, about 52%. And how about the guiding shape? Is maybe we have to prepare about the backup force type guiding. Maybe we need a good backup force and for the deliver this bus guide wire system. Now, how about the success rate? So actually, this paper is corrected 23 cases, and it's a very small number, but a very amazing with a very high ratio of the success, and about 96% is success. I'll show another paper. This is another good paper for the considering the reverse wire technique. And please look at this figure, and please look at this one. So we have to think about the carrying angle, and the excess 19-degree angle. And so maybe this bifurcation is very suitable for the performing the reverse guide wire technique. I like that. And how about the success rate is very high ratio. Actually, a few number actually from this paper is 12 cases, but 100% success. And I'll show the reverse wire technique actual procedure. This is and the 110 and 110 bifurcation region. We can see the left main trunk region. We can see the ostial LED region like that. And the angle is the excess 19 degree. And in this time, I perform the reverse wire. I will show the steps and deliver and forwarded guide wire to the circumflex like that. Actually, I chose the 7-phase guiding. And sometimes we need a good backup force for the deliver this system. And then so I pull back the crusade, the keeping this guide wire position. Just only the pull back crusade like this. And after that, pull back forward guide wire and automatically get advanced to the this LED. And so in this time, I chose the Sion black and polymer jacket guide wire, and I consider about the lubricity. And get advanced like that, more distal part. And then so I take a crusade and extend for the guide wire and to the new guide wire using the microcatheter. And the fifth technique is a parallel guide wire technique. The benefits is the tracking first wire route. And please look at this picture. And if this first guide wire and get advanced the correct way, and from the proximal part of the CTO, we have to purchase, we have to trace this first guide wire route at the proximal site. Very easy way to using the crusade parallel guide wire technique, we can perform this purchase. And another one is the strong backup force, and this is the benefits, and we can perform the coaxial manipulating. And I will show that this and the in vitro and in vitro test. This one, this slide is show the evaluation of the guide wire support. This orange line is a single lumen. And this graph is show the horizontal line, the length of the guide wire advancement. And the vertical line is a pushing force, and the upper is higher, and then the downward is lower. And this orange line shows the single lumen microcatheter, and get advanced this guide wire more distal, and using this single lumen, and very easy to occur the flexor that this microcatheter. In this time, the pushing force is down and compared with the crusade. And I will show the actual number ground force that using the crusade. So this, and in this time, so we check the pushing force using the Gaia first. If we use a crusade, it's a 3.7 to the 3.8 ground force. But on the other hand, if we use the single lumen microcatheter, is compared with the crusade, very weak the pushing force. I show the evaluation of the coaxial manipulating, and the upper one is I show the crusade picture in vitro model, and this one is in the using the single lumen microcatheter, very easy to occur the flexor. The crusade is maintaining the coaxial position towards CTO region. And I will show the actual case. This is RCA CTO. We can see the CTO region is the middle part of RCA. And there, in this time, I choose XTR guide wire as the first guide wire for the negotiation the CTO region. But unfortunately, this guide wire get advanced to the subintimate space. And then so I decided to perform the crusade parallel guide wire technique. And due to the crusade parallel guide wire technique, we can get good back and forth and good coaxial position. And even if I choose the JR4, but in this time I get a good back and forth. And the actual correct route is upward compared with the first guide wire. And finally, and I can get advanced this guide first wire to the correct way to the true lumen like this. And I show the last technique. This one is a crusade side branch back curve. Now, I already explained about if we use the single lumen microcatheter for the CTO region, very easy to occur the flexor, very easy to occur the movement of the microcatheter position. But on the other hand, crusade is the position is fixed. And due to the using the crusade side branch back curve system, we can get strong back and forth, and we can perform the coaxial manipulating. I show the actual case. This is a CTO, and this CTO from the beginning, the outside part of LED. And I decided to perform the crusade side branch backup system. I insertion the conventional guide wire to the circumference, and additionally, I get advanced crusade, and I insertion to the CTO guide wire. For this system, we can get a good back force, and we can perform the coaxial manipulating. And I show the special technique. This one is a crusade side branch back with balloon anchoring. This we can see is as a CTO from the beginning like that. And in this time, I insertion the conventional guide wires and 2 guide wire to this cone branch, 1 guide wire for the crusade. Another one is a balloon trapping. And after that balloon trapping, we can get very, very good back and forth like that. I will show another and advancing the technique and using the crusade side branch and with IBUS guided. Please look at this one. And the advanced system is using double lumen microcatheter for the IBUS guided entry. And due to the double lumen microcatheter gave us good back and forth and the prevention for the prolapsing of the guide wire like that. Please look at the schema. And I will show the actual case. And this is LACTO. And this guide wire get advanced to the side branch, a big septal branch. And I inserted the IBUS, and additionally I inserted the crusade. And after that, we can get good back and forth. For the performing this and the IBUS guided entry, we have the tips. Please do the closer branch, and the CTO region is better. And after that, actually this region is very, very hard. And I escalated the guide wire up to the Conquest Pro 12. And but we can confirm simultaneously later this guide wire position. Looks like this guide wire position be in the intimate plaque. Another problem is how to remove the crusade. And so my recommendation, please perform the balloon trapping for the fixing the guide wire position. And if you use the 6 French guiding, and I recommend that please use a designated trapping balloon like a Kaneka Kusabi. And if you use a 7 French or the 8 French, my recommendation, please use the designated or the conventional balloon. The size is more than 2.5 millimeter, my recommendation. And I will give the attention. And please care about the air contamination when remove the devices. Take home message. And the crusade function is one is a delivery of a big angle curve, and the second one is a delivery of the second wire via first wire route. And another one is a backup force. And especially the Crusade specification is over the wire structure is double layer and not double tube. And due to the double tube, we can get good backup force and avoiding kinking. And using the Crusade, we have the many techniques. Please perform these techniques. Thank you for attention.
Thank you very much.
Welcome.
Okay, all right. So thank you very much, Nagamatsu, for the really nice presentation.
Thank you very
much.
much.
Yes, so let's move to our second speaker,
okay.
Dr. Asri Ranga. So Dr. Asri Ranga will talk regarding the pod technique. So there will be 15 minutes, Asri. So Asri, please. And then for the audience, you can have your question. Just fill in the Q&A at the bottom of your monitor. So we'll read the question from you, and then we will deliver to the speakers. Please, Asri, your time.
Salam. Can you hear me, Donnie?
Yes, very clear.
Hi, and Selamat Hari Merdeka, and thanks for ISIC having me, and also Kanekan Biosensor. And without further ado, I'd like to talk on pod and kissing technique in bifurcation treatment. I'm from a public hospital. This is my hospital, Sedang, from Malaysia. And we are quite a busy center. This is my new center. Hopefully it will be up by next year with 6 cath labs. And without much delay, potential conflict interest, nothing much, but I'd like to thank Dr. Chu Kim Hui from CVSKL and Dr. Viraj for actually giving me most of the slides. And basic learning objectives, why we need to kiss and pod, and how to kiss and pod. So I'll go quickly, what is the concept of kissing and pod? So whenever you have a single stand or two stands, and you actually dilate into the stand struts, you actually deform the stand. And we know this from bench studies and so on. So there's always deformation. So you have to fix this deformation. I will show you more cartoons and details after this. So what I would like to tell you is kissing balloon inflation is obligatory for two stand techniques. Many studies, and this is a study called the COP3, almost 10 years ago, where they looked at 1,700 patients, and in 300 patients with two stand strategy, basically, if you do not kiss, fine. If there's no final kissing inflation, the rate of MACE is much higher. It's almost 13% compared to as when you have final kissing inflation. So this is for two stand strategy. Kissing is obligatory. But how about single main vessel stand, single or provisional side branch standing strategy? So you have one stand across a side branch. Here, the data, this is from one of the more prominent studies, the Nordic-Baltic bifurcation study, which showed that at 6 months, there's no difference if you kiss or you don't kiss. And this study has been even propagated to 5 years. But don't get confused. Huh? This is for single KBR, kissing balloon inflation, when we compromise our side branch. But I like to remind the audience that there's a disconnect between angiographic and functional significance. Because if you use a physiology now, more of us are using FFR and things like that, you find that in 1/3 of the cases only is abnormal, despite looking at the very pinched, like ostium circ here, the FFR is still 0.92. So you have to use FFR for these cases, so you don't unnecessarily do side branch dilatation and so on. And you have to know your stents very well. So DS designs and so on. The newer stents, Synergy Expedition, Onyx, Ultimate Biometrics, and so on, you have to know how much they can expand. So it's not all stents which can go up. Okay, so if you have the new 4.550 stents, hopefully in the future you'll have more of these stents. And the reason being, look here, when you have a 3.0 stent and you go up 4.5, look at the deformation of the stent as opposed to 3.5, and you go with the same balloon. So this actually impacts on MACE, the outcomes, and so on. So you must know your stents very well. But apart from that, I think imaging is the key. I have not the time here to talk about it, but if you want a successful bifurcation PCI done, you need to use IVUS or OCT. There are lots of criteria. This is the left main criteria, 5, 6, 7, 8 millimeters. So imaging is the key. You know you have achieved it or not. So I will tell you how to kiss and how to pot and how to do it. So basically, a prerequisite to a good kiss is you need proximal optimization technique or pot. So most of the bifurcation techniques, you need 2 pots. Except DK crush, you need 3 pots. So you pot, then you side branch wire, then you use a non-compliant balloon at high pressures for adequate duration. Then you pot again before you end the procedure. So there are many formulas to actually try to see what is the size like, Murray's law, and you know, you have Finex, you have Kasab formula. So I will make this actually more simplified. You also have Mitsudo's formula. So basically, it's basically the side branch, the distal segment plus a branch times 2/3. So this is in our minds when we do this. Whenever we case, always remember this is your proximal segment. If you use a 4.5 balloon and 4, you'll go to 5.7 in proximal segment roughly. If you use a 4 millimeter balloon in the both branches, you'll go to 5.4. So you must know your proximal segment. Rarely I need to use actually 2 more than 4 millimeter balloons. That is why most of the time when we use, we need a 7 French catheter, guiding catheter. We can sometimes do with a 6 French, but 6 French might not be able to hold 2 4 millimeter balloons, and you might actually compromise. You need to do sequential. So always, if possible, use a 7 French guiding, and always keep these numbers in mind so that you don't perforate your proximal vessel, especially if there's calcium. And if it's the LED or RCA, left mains usually can take bigger. So again, showing you in kissing, if you just balloon the side branch, even if you use a 1.5 millimeter balloon, is enough to deform your stand strut opposite to it. And actually, there are many formulas like what I mentioned, but the one I commonly use is side branch, distal main vessel, and then you times 2/3, then you know what is a proximal reference vessel diameter is going to be like. And this is a cartoon spying. So you have a stand size to the proximal. If you have a stand size to the proximal vessel, this is what will happen. You will have the whole carina shifting up, and you're going to deform, and you're going to lose a side branch. It will be very difficult to actually salvage this. But if you size your stand according to distal side branch, this is where OCT or IVERS comes in very handy. And then you pot the proximal part of it. You can see how nicely it actually, you know, it doesn't deform the carina. So this is the whole idea of pot. And in the past, more than 5 years ago, even a lot of people did not do pot. They just did kissing, and they were quite happy. But I'll show you why you need to pot. And what's very important is this is the most important slide in this lecture: where to pot, how to pot. So you must understand that the parallelism ceases at the inner edge of the radio opacity of the balloon. So this is where you need to place your balloon carefully. So you need to magnify as possible. You know, you cannot just say, you know, balloon go distally. If you go, balloon goes more distally, you lose the whole advantage and you'll crush the carina. If balloon goes more proximally, you will not actually achieve a good pot. So the placement of the balloon is very important. It should be 1-to-1 with the vessel size. Again, I reiterate, the only way you can really get 1-to-1 if you use imaging. This is an example of a cipher selector in the past, and you can see where you need to add, maybe a bit deeper. Sometimes it's not easy. It's not an exact science, but we try to be as parallel to the inner part of the marker as possible, so that you get, you know, so you need to magnify if possible. Sometimes you stand boost. It's not easy, as I said. Sometimes the second wire here might help you. Okay, so this is where you place the balloon just before the carina. So if you look here, if you do pot with OCT, you can show that the bifurcation, the ostium is actually much more bigger here. So what pot does is it just proper sizing proximal and distal main vessel. Like here, they put a 3 millimeter stand, you pot the proximal, you can see it's actually expanded better. There's reduced risk of wire exchange outside the proximal part. So you won't go beyond the stand struts, and when you put the balloon, you can deform the stand. Then it opens access to side branch. It facilitates side branch, especially through the distal strut. And this is again showing you a simple way, a stand across and see how much deformation has happened. Imagine if this stand is shorter, sometimes the entire stand can actually go to the other side. So no matter how small a balloon you use, you must always port and use port for the main vessel. So potential benefits again: reduce strut malapposition in the main vessel, reduces inadvertent abdominal rewiring of the main vessel, open the stand cells overlying the side branch, so easier to facilitate recrossing, and optimizes the final geometry. Another thing important is after port, you have to see where your wire crosses. So proximal crossing is actually a no-no except in TK crush. Most of the time we prefer distal crossing if possible, because if you don't, you can see here what happens. Here you got a nice scaffold in distal crossing, but here you will have a gap, and you can actually have stand struts impinging the ostium of your side branch. Again, showing you if you have proximal wire crossing, there's a gap here. And if you have distal wire crossing, the stand actually scaffolds better. And again, this is OCT showing a distal cell rewiring. The stand struts actually oppose the scaffold your side branch. Here you have a gap. So this actually causes more in distal cell. Again, OCT here showing crossing and proximal cell. You can see the stand struts, even this OCT reconstructed picture. You got more stand struts malopposed, and this actually can cause more issues. So it's not only in your conventional, TAP stands, struts and so on, even in culotte. Some people do not understand. They feel that in culotte it should be okay because you got another stand going through. But look here, if you have a distal recross, then you have a nicely formed geometry and carina. But if you do a proximal recross and you actually if you put a proximal recross, not distal, and you put a stand across, what happens is part of the first stand, the original stand, the first stand will get lifted up and it will form like a carina sticking in the middle. The metal is here instead of being at the vessel wall. So even in culotte standing, it's actually very important. Only in DK crush, the way it's done, you can actually go through the proximal stand strut crossing and achieve good results. And again, this is another concept where if you use, some people use compliant versus non-compliant. Compliant is easier to cross, but if you use if you use compliant balloons, what happens is, look here, this is two 4mm balloons. This is proximal part of the vessel. This is distal part, and you can see this is the bifurcation. And here you have actually over expansion at the side branch ostium. So if you use compliant balloons, you can actually overexpand. So preferably for kissing, we use NC balloons to prevent re-expansion, and also you can post-dilate the vessel at the same time. This is another concept where most of us do not look at it, especially the left main, but duration of balloon inflation also actually ensures larger, lumen gain. As you can see, 5 seconds and 60 seconds. Obviously, we will not inflate some left main to 60 seconds. And some people actually do repeated, expansion of the balloon to achieve bigger. But basically, in left main, with bigger balloons, 5 seconds is at the most I actually inflate. But you must know your balloons very well, because some of the older balloons might take longer time to deflate and it can cause ischemia. The newer balloons can actually deflate much faster, so you have to take that into account. But in LAD, RCA, circumflex vessel, maybe longer, you can think of longer time to inflate the vessels. The other thing is, when you perform KBI, which balloon goes up first? Do you do both simultaneously? So this one here is showing the first panel where the main artery goes up and then subsequently the side branch. This one, both goes up at the same time. And the last one, the side branch goes up high, then you have both actually going up. So the last one, actually, you can see the lumen is bigger. Basically, even though you have a side branch stand, you must optimize the strength properly. So the first inflation for your side branch, you can actually go up at a higher atmosphere. Most of the time when I go up here, I just go to 10 to 12 just for final kissing. But if you want to actually optimize better, the first inflation, so side branch, you might need to go up even to 20 atmospheres. And this is another thing most of us do not even think about. your balloon overlap. So if you have long balloon overlap, as you can see in A, B, C, D, E, you can actually cause elliptical deformation of the stand proximal in the main vessel, proximal to the bifurcation, as you can see, and as opposed to minimal balloon overlap. So now there are people talking about having as minimum as possible balloon overlap only in the area of confluence, so that you might not even need to port if you want to do away with port, especially if this proximal segment is less than 8 millimeters, shortest than your shortest balloon, you don't want to damage or whatever, you can actually consider that. So minimal balloon overlap, if possible, is the way to go. And as you can see here, with minimal balloon overlap, your proximal stand is actually the roundness is preserved here. It becomes elliptical, so you can actually measure this very well in OCT, and you can actually have eccentric. What happens is when you have eccentrically the index here, the eccentricity is very eccentric. You can have asymmetrical expansion, and you can have thrombus formation, and you can see sometimes this actually even predisposes to more intimal hyperplasia. And finally, so if you were to do bifurcation, you have to know what techniques you're going to use. If you're more than 70 degrees T or T-tap, if less than 70 degrees DK crush or cool out, but DK crush you can use for almost all of the bifurcations. And what type, how you're going to do, basically you port first, then you use your kissing balloon inflation, and then your final port. You should not emit your final port. Just a word of caution, if you single stand, you might not even need to actually do kissing if the side branch is not jail, but you still need to do a proper port. That's very important. And sometimes if you use a 6 French, you cannot put 2 big balloons. Sometimes you might need to do sequential balloon inflation, but always remember, you still need to do the final port. Especially you cannot put 2 4 balloons or 3.5 4 in a 6 French, especially if you're using old balloons. So this is my take-home message. Kissing balloon inflation corrects the geometry after side branch inflation across stand struts. Kissing balloon is mandatory for 2 stand techniques. Routine KBI for single stand provisional is generally not encouraged unless the side branch is compromised. And port is very important, because port before distal strut wiring, port after your KBI, but you always use non-compliant balloons at high pressure and adequate duration. Avoid long balloon overlaps. And finally, as I mentioned, KBI must always followed by another port. Thank you. And hopefully next year, my new center will be up. And because of the COVID, it's been delayed a bit. But anyway, thank you very much.
Thank you very much, Tasri, for the very nice presentation. So we learned so much. So we have a discussion. I think it's around 10 minutes. So I think we have 2 of our colleague, Dr. Ismir and Dr. Nahar. So let's start with Dr. Ismir. Is there anything to add or anything to question Dr. Ismir, please?
Okay, thank you, Dr. Dani. Nice to meet you all, the panelists, Dr. Nagamatsu and Dr. Asiranga. First of all, that I would like to have a comment, and it's very enjoyable to learn about a crusade from Dr. Nagamatsu. As long as we know that the PCI, we face on some wiring difficulty, especially in acute angulation of the side branch or target vessels. And also when we want to perform CTO intervention without stump while the side branch is near, so the wire tend to enter the side branch. And what I have learned from Dr. Nagamatsu's explanation, that the crusade catheter is helpful to compromise with the wiring issue technique. And also that facilitated reverse wire with polymer coated wire and crusade have also high successful rate to enter the extreme angle of the side branch. But in case of we did not have a crusade in our CAD lab, some of my experience in PCI of bifurcation with acute angle side branch with suitable plug position can also modify it with the bulking technique of the plug with ballooning or rotablation to widen the lumen and reduce the lesion angle. But this is not routinely done and recommended because of the high risk procedure, and it also a fortune to not lose the side branch because the potential of the plaque shifting of the side branch if the anatomical plaque is not suitable. So one of my question to Dr. Nagamatsu regarding the crusade, maybe all the audience will also ask, what is the intention to make a big wire curve in double lumen catheter? That's my first point from Dr. Nagamatsu explanation. And also to Dr. Asriranga, it is a very comprehensive explanation to optimize bifurcation PCI regarding step-by-step of kissing balloon, balloon size, position, and pot. And we know that the most important of dual stent strategy is to protect or cover all the carina. So the key is to cover all the carina, first pot and second pot after kissing balloon inflation is reduced the target lesion revascularization more than 12% than without pot. And then the side branch rewiring as distal as possible optimization using the stent boost is one of the tips that I have. And also we can use the imaging like IFUS and OCT. And also we know that the catheter of the character of the stent is really important, how big that we can expand the stent because different size from the branch to the main branch. And also if we didn't have any IFUS or OCT, we can use the formulation like Finet or others. And also the need for ischemia testing over the gel side branch after doing provisional stenting to decide whether we have to put another stent bailout in bifurcation lesion. I think that's all my comment to both of the panelists, Dr. Doni. Thank you.
All right. Okay. Thank you, Dr. Ismir. So I think we have one question to Dr. Nagamatsu, right? Yes. Regarding the wire angulation, Ismir, if I'm not mistaken.
I mean that why we have to make a bigger angulation on the crusade.
Yeah, please, Dr. Nagamatsu.
Okay. As I would like to a little bit to share my slide. May I? Okay. And maybe you can see my slide. So this slide explains about the wire curve shape. And so my recommendation, the shape is where we have to make a big curve is from the tip to the 2 to 4 centimeter. And if the side branch have the big side branch, and I mean the side branch and the side branch, and so sometimes very easy to get advanced automatically to the side branch and side branch. And in this time, so I choose shorter one, and shorter one. But normally I make 4 centimeter from the tip. And another problem is the sharp shape or the round shape, and which is better. So my recommendation, firstly, please make a round shape because, and even if they get advanced to the side branch, so this a second guide wire, but after that, we have to extend the guide wire using the single lumen microcatheter. If we create a very sharp curve, sometimes very difficult to get advanced to the additional microcatheter. So my recommendation, please make a round curve first. And if it is very difficult to deliver and using this round curve to the distal part of this reverse guide wire technique system, and please change the shape, the shape to from the round to the sharp curve for the deliver. This is my recommendation. Thank you.
Okay. Thank you very much. So I think we can. I think there's no question to Dr. Asri, right, Ismir? So we can move to Dr. Nahar. Please, Dr. Nahar.
Okay. Evening, Dr. Asri. I have a question about the design of the stent. Can we use the closed cell for the bifurcation stenting, like your slide? For example, you stent the past stent we know the cipher is the closed cell.
Yeah.
Closed cell design.
Opinion.
I think now most of the stents are basically open cell,
Yes.
because I know last time with Cypher we had a lot of problems with the side branch and things like that. But now most of the, I think, design, if possible, especially you're going for large bifurcations like left main and circumflex and thing, basically I actually go for closed cell. I mean, sorry, open cell. In fact, even the current stents might not be enough to attend. So for the big vessels, we still are finding for the optimal stents. You know, although we know Synergy, Onyx, they're 5.0. In fact, I'm actually eagerly. I think Boston is supposed to launch their Megatron stent maybe end of next year. So that one you're looking for like 6.0. Size and so on. And we had a self-expanding Stentis, but unfortunately, the company has closed shop, due to other reasons and things like that. So, but that one, the radial stent might not be so strong. So the problem is when you have large vessel, you need to have strong radial force, good opacity, and also side branch access. So far, we have not found the ideal stent yet. So we have to make do with what we have.
Yes.
Okay, good point. Any other question, Dr. Naha?
No.
Or is enough?
Maybe for Dr. Nakama. So, if we are beginner to use the crusade, the tips of the two wires, if there is a kinking, how to retrieve it? How to
Okay, and the kinking phenomenon is easy to occur. Like two balloons.
Yes.
Yeah, and maybe there are same reason there, but the benefit and using the crusade and before and performing the kissing balloon is there sometimes a little bit difficult to occur the wire twisting and using the crusade. So this is a benefit for the and the crusade.
Crusade.
Okay,
Dr. Dani.
Thank you.
Thank you, Dr. Nakamasu.
Thank you.
That's good. So, okay, we have 1 minute. Asri, so one of your slides mentioned that how to perform a proper kissing balloon, starting from the main branch and then simultaneous kissing, and then side branch, and then simultaneous kissing, right?
Yeah.
Because there is a lot of variation how to do that. So one of my mentor mentioned that just starting from the side branch first and then main branch first and finishing with kissing. So it is a matter or not? So in the order to do it.
Actually, the kissing order you can do simultaneously, but what's more important is main vessel and side branch you must optimize first. So when you implant the stent, for example, in the side branch, some people just go very nominal and then they don't pull back and go high pressure. Sometimes that high pressure might not be enough. So you might need to do imaging. You might need to go high pressure first. If you have done high pressure dilatation and imaging proceed, so the kissing is just to make it nice, So when you do kissing, you don't even have to go high pressure. You just go 12, you are okay. But within stents, you can go much higher. But the initial optimization of the stent must be done at high pressure, 20, maybe 18. So kissing is just to make sure that the stents are properly, they don't deform. So you can go at low. So whatever you do, you must optimize the stents first, then you can do even simultaneous. So most of the time, some people do sequential for some reason, but you must always better simultaneous so the carina doesn't shift so much, and then you pop. Yeah.
Yeah, that's very, very important. So thank you very much, Asri.
Dr. Asri?
Yeah.
Oh, yeah. Okay, Ismail,
there's a question from Dr. Mangiring. If we don't have a big balloon for pot, can we use two balloons, Dr. Asri?
So this is where the whole problem started. So in the past, some people say you can use two, but if you use two, your proximal lumen won't be round; it'll be eccentric. So it will cause all the problems you are seeing. So the largest balloon, unfortunately, we have is a 5.4 balloon. So only in the left main you might need a. So maybe the companies have to look at the producing a 6.0 balloon in the future or bigger balloons. So there's no exact, if more than 5.0, I have difficulty. I know what to do.
Yeah. But the pot must be one balloon, right? That's
yes.
I think
The
that's
whole idea
the most
pot is one
important thing.
balloon.
So second question, maybe Dr. Nahar, what is the?
I would like to ask Dr. Asri Rangga about whether we choose to make a first pot or only kissing first.
Okay. You see, the problem is, of course, in real life, you can maybe try to, not to do the first spot, to do the case faster, but the problem is your wire, if you don't port properly, sometimes you cannot, unless it's OCT guided, it's difficult for you to go through the distal stent strut. You can go through proximal, you can even go behind the stent struts and so on. So even though we are tempted not to do the first spot, we think we can easily cross. My advice is, if possible, please do the first spot. Yeah, you have to follow. If you follow the scheme, most of the time you'll get it right. And after a while, it'll become second nature. You can do it very fast. In fact, like for DK crush, what I do is sometimes I park my crush balloon inside, and then I recross, and I can actually pull back and go up high pressure. So you have shortcuts. But I think you take shortcuts in port, sometimes you can compromise. Yeah.
Yes, you're right.
Thank you.
Okay, that's all. Okay.
Mute.
Sorry. So thank you very much for Dr. Nagamatsu and Asri for the really nice presentation and nice discussion. So due to limited of time, so we move to other session. So there will be a case presentation. Of course, Dr. Nagamatsu and Asri, please join us and then discuss regarding this presentation. So we have a presentation from Dr. Arwin Mangko Anom. So the case presentation will be regarding the complex bifurcation PCI. So Arwin, please.
Thank you, Dr. Doni. Sorry. Okay. Good afternoon, everyone. My name is Arwin Saleh. I'm from Jakarta, Harapan Kita Hospital in Jakarta, Indonesia. This afternoon, I would like to present a complex bifurcation PCI, and I will focus on the culotte stenting step by step. This is the case background. Mr. AM, 62 years old, came with typical angina, even on daily activity. The ECG showed that there is no Q wave at the anterior. Even on the echocardiography showed ejection fraction was 20 to 25%. And from the cardiac spec, ischemic burden is 2.5%. We don't know yet. Maybe this is because of balance ischemia, because this patient has a 3-vessel disease. Kidney function was normal, and then the heart team decided to PCI LAD. This is the diagnostic of angio of this patient. The left-hand side is a cranial view. In the middle is a spider view and the LCA. From the LCA, we could appreciate that there is a severe stenosis of the diagonal and in the mid LAD. And also, if we see clearly at the left main, there is maybe mild moderate lesion on the left main. And also, there is stenosis at the proximal of the circumflex here. And we could not see the distal of RCA of this patient. Maybe that area is already impacted. So we do a coronary physiologic test first. We have a 0.99 AFR on the proximal LAD and 0.45 at the distal diagonal, and we have 0.72 at the distal LAD. Because this patient has poor ejection fraction, so we try to preserve all the branches. And the circumflex was normal, 0.83 from the IFR. We proceed to PCI the diagonal first. I put a 2.0 time 15 balloon through the diagonal branch here. And then this is the 2.5 semi-compliant balloon, and I inflate it to 12 atm. This modified balloon, gel balloon technique was introduced by Dr. Saito in 2017. And then I inflate my stand 2.75 times 38 millimeter up to 14 atm, while my gel balloon inflated around 10 atm. From the upper right hand side, we could see that my balloon was easily retracted and pulled out through the guiding catheter, and still the side branch was preserved well. Then this is next step. I rewiring through the stand strut at the proximal LED through the distal LED, and this is the stand boost. I put the 2.0 balloon to open the strut, but at the ATM the balloon was burst, and I changed to the 2.5 times 20 millimeter balloon and inflated about 14 to 16 ATM. And then I placed next slide and next stand depth biometric alpha 2.75 29 millimeter. I put a distally, so I plan to do. I put another stand at the proximal of the LED. This is, we could see that this picture from the stand boost, there is a 2 or 3 strut protrude to the left main. So actually I planned a minimal culotte, so I put just a little bit on this stand strut. And then I put another desk 3.0 times 20 up to 14 ATM. And I inflate the stand here. And then I crossing another wire to through the diagonal. And I always leave the gel balloon as an anchor, because if we see closely, when I put my balloon here, the guiding was kicked out a little bit. And after the balloon already insert into the stand, I retract and pull out the gel diagonal wire. And then I do a kiss with simultaneous kiss with 10 ATM at the 25 at the diagonal and 3.0 at the LED balloon. And then I do pot with 3 to 5 times 12 millimeter NC up to 18. And I put at this marker at this carina. So I inflate it up to 18 ATM, and the result is acceptable. And this is the final result. This proximal, this left main looks tight, but the IFR showed that at the distal of the diagonal was 0.95 and the distal LED was 0.98. And this is my last slide. The culotte technique is, there is several steps. The step 1 is pre-dilatation of the main and side branch. And then the step 2, side branch stand deployment. And after that, recross into main branch and dilate. And main branch stand positioning and deployment. And then recross again and side stand, and then final case and pot. There is advantages of this culotte technique. Of course, this technique good radial strength and complete coverage, and the best immediate angiographic result. It may also guarantee a more homogeneous of distribution of the strut and drug, and can be used for wide variety of bifurcation angle. But there is also several disadvantages for this technique. This is complex and time consuming, rewiring both of branches through the stem strut can be challenging and more overlapping metal in main branch. I did that case around 30 minutes of fluoro time, and I used around 120 of contrast volume. That's all my presentation. Thank you, Dr.
Okay, thank you, Dr. Arwin. So let's move to the second presentation. So we will discuss later on both of the cases. So let's move forward to Dr. Dian Larasati Munawar to present her case. Please, Ati.
Thank you, Dr. Doni. Okay. Let me share my slide first then. Okay. Good afternoon, good evening, good evening. Thank you for the opportunity. My name is Dian Larasati Munawar and I'm from Bina Walia Cardiac Center, Jakarta. And I'm here to present my case about successful PCI in acute bending proximal double CTO SX with CTO RCA using single and dual lumen catheter. So for our case today, we have 55 years old male. He had a history of chest pain 3 weeks ago with diaphoresis. Beforehand, he had an uncontrolled diabetes since 5 years ago and hypertension and dyslipidemia. And he was referred from Balikpapan because he was known for three-vessel disease and suggested to do KBH, but the patient is refused to do so. So that's why he came to us. And then from his examination result, the LDL showed still quite high, and there are normal creatinine level with a high A1C and increased level of proBNP. And his echo result, there was a LV dilation with reduced ejection fraction and the well motion abnormality in epicoseptal. And the ECG showed the old infarction in anterior. And he was done angiographically before he came to us, and this is the result. You can appreciate here there was a long CTO on the circ, but we can see that the circ is quite big because it's shown that there are several of obtuse marginal vessel there, and there was a subtotal stenosis in the proximal iliac and another CTO on the RCA with a diffuse distal vessel. So from here, we can see that the circ has the proximal cap is tapered and quite long CTO length with a double CTO from circ to the OM1 and the circ to the OM2. And then there are no calcification there, and the distal cap was diffuse, and the distal cap is in the bifurcation, and there are unclear collateral vessel from the ipsilateral. And from the syntax score, this patient is recommendation is for KBH, but he reviewed, so we don't use this. So our strategy for this lesion is we use there are double CTO insert that with a tapered proximal cap. So we still prefer to do integrate wire escalation, but we noticed that there are acute bending in the proximal circ. It will be something problem, and then we can use single and dual lumen catheter. It's a very essential tool in this case. And then because it's very diffuse, we use IFO study, and we will give this patient 1 or 2 stents on the circ, and don't forget to do POD. And the most important thing is we have to keep it open, all the obtuse marginal vessel. So from here, we can see that acute bending on the proximal circ, and the wire kept going to the ramus, the big ramus in the proximal part. We use a round through for our workhorse wire, followed by Mizuki. In this kind of lesion, usually we use microcatheter that has a distal tip angulation, so it can facilitate guide wire and advancement through the areas of tortuosity. However, this kind of tools it's not available in our cath lab. So we use a modified Mizuki. We bend the proximal tip of the Mizuki. So after the workhorse wire goes through the proximal cap, the Mizuki can easily go through the bending part. And then after it goes into the proximal cap, the bending on the proximal side of the circ, it can be a good backup support for this lesion. So that's why after we exchange the workhorse wire to XTA wire, the wire can go easily through the CTO lesion, and we confirm it. The wire goes to the first OM. And then afterwards, we try to insert to the small balloon, 1.106 millimeter balloon, but it cannot cross the lesion. And then we change the microcatheter to turnpike spiral that has a good drilling support in this microcatheter, and then it can go easily to distal. And then we exchange into the workhorse wire and then open it a bit with a 1.5 balloon, so it has a bigger proximal size to put another microcatheter crusade for the next CTO lesion on the circ to the OM2. So from here, with a good backup support from the crusade, the XTA wire can go easily through the OM second. From here, you can see that the wire can go easily to through the lesion. So, and then we confirm it with another injection. So the wire goes through the true lumen in the OM2, and then we open it up a bit with 2.0 balloon. Then this is the result. So we did an IVA study for this case. It looks like a very diffuse fibrous plaque in the city of the circ with the quite small diameter on the distal vessel, 2.5, and then the proximal is around 3.5. So we decided to do predeletion with scoring NC 2.5 balloon, and then followed with a long DES 2.5. And then we don't forget to do pot with 3.25 NC balloon. And then this is the result. So we did a post-stenting bus. Seems looks like a very acceptable result with a good apposition and expansion without the edge dissection. So we still have the RCA CTO. You can see here that the proximal cap is tapered with a short length. And fortunately, we have no calcification, although the distal cap is very diffuse and still clear with a collateral vessel very big from the epicardial. But we're still trying to do an integrate wire escalation in this lesion. We use XTA wire. It performs a subintimal tracking, but we decided to do a parallel wire technique using crusade. And then through the side hole of the microcatheter, we use Gaia first, and then it's serving through the RV branch. But it's a good thing because it will shorten the CTO length. Then we can easily rerouting through the crusade using the Gaia first, and then goes through the true lumen on the distal RCA. And then after we confirm that it was on the right track, to have a better support, we exchanged the crusade to the Mizuki 1.8 French. And then we confirm it through the contralateral guiding injection and show that the Gaia first is goes into the true lumen on the right PL. So in this case, we did also a SPIFA study. We decided to put 3 DES, a long DES stand, and then because it's shown that it's very fibrotic, diffuse, so we decided to put from the ostial to the distal. So we did a preparation on this vessel using 2.0 balloon, followed by 2.5 scoring balloon. And then we put the distal dash 3.0 long stand, followed by 3.5 long stand, and then in the ostial part, 3.5 long stand, and then followed by port in the RV branch with 4.0 below. So this is the final result on the CERT and the RCA. We also put stand in this LAD part. So for the summary on this case, the CTO PCI is alternative for KBH, and the ischemic symptom improvement is the primary goals in CTO PCI. The use of microcatheter is essential for guide wire manipulation and have a better backup support. And in long CTO, integrated wire escalation may still best option for CTO PCI if we use the right tools and technique. Thank you.
All right, thank you, Dr. Dian or Dr. Ati. Really interesting case. And then, so we have two case presentations. So I would invite maybe Dr. Nahar first to comment. Yeah, in order to Dr. Arvin's case. Dr. Nahar.
Yeah, congratulations, Dr. Ati.
Thank you,
Good
Doc.
job. I think it's very difficult case, and you can do this case with properly. And I don't have a comment. Only how many times the fluoro time.
The duration of this procedure is 250 minutes, around 4 hours actually, Doc, because it's several CTOs with subtotal stenosis, and on the LAD we did we did a left main and through the proximal PCI because after we see the lesion on the RCA, we keep the septal as the backup strategy for the CTO RCA. So we give the stent a little bit through the left main to keep the septal is open, so there's no strut in the first septal. But fortunately, integrated wire escalation is enough to open the RCA, so we didn't do retrograde at all in this case.
Okay, thank you, Dr.
Right.
For Dr. Arvin, if we have a coronary syndrome with bifurcation lesion, what should we do if we have to do the single stent or two stent? And then if we do the two stent strategy, what is the best choice for the acute coronary syndrome? Because your case is maybe the stable angina.
Okay, thank you, Dr. Nahar. You mean that if patient came with maybe MI?
Yes.
STEMI patient. I think if STEMI patient, we have to quick in and quick out. So I think professional one stent strategy is the best option for that kind of patient, because this patient is in stable condition. We plan a complex bifurcation stenting, and we also plan to preserve every branch before because this patient has a low ejection fraction, Dr. Nahar. Thank you.
Okay, thank you, Dr. Ras.
Dr. Ismir?
Yeah, I think congratulations to both of the presenter, Dr. Ati and Dr. Arvin. Both of them have a very challenging case. For Dr. Arvin, regarding the patient with a high risk in ejection fraction is very low. Selective PCI based on the clinical and using FFR is excellent to reduce symptoms and optimize clinical condition. So in this case, Dr. Arvin, did you use NC balloon for kissing balloon inflation? And also, did you do post dilation after stent diagonal due to the balloon trapping that you use? And because you use a cooler technique, you put 2 layers on the of stand on the main branch. How about the APT duration that you will prescribe to this patient? And I think that if you use IFUS, it might be helpful to adjust the stand size and do first pot, and after that do your step you've done. But I think all you've done is very, very good, and we've learned a lot. For Dr. Ati, I think that the decision that you use a double lumen catheter after crossing the first side branch of obtuse marginalis 1 is a good strategy due not to losing the wire, because it's very difficult to cross the OM1 first and give a better support so you can easily wire and entering the OM2 lesion. And also the professional stenting is the chosen strategy, very, very right to simplify the procedure. Well done, Dr. Ati.
Okay, thank you, Dr. Amir. So we're going to answer first, Dr. Arwin, maybe?
Thank you, Dr. Doni. Thank you for the question, Dr. Ismir. For the final case, I use, maybe I share the screen first. Final case. Yes, this one. Yes, I do final case with 2.75 NC and also 3.0 balloon NC. I inflate up to 10 ATM simultaneously, and then I pot using 3 to 5 12 millimeter also NC balloon up to 18 ATM, because we could see that from the stand boost at overlap area there is a bit dog boning. So I inflate to high pressure of the NC balloon. And also you also asked about the gel balloon. Wait. Yes, for the gel balloon, this is a 2.0 semi-compliant balloon that I put in the small branch of the diagonal. I put the marker of this small balloon is at the carina. So I inflate it up to 10 ATM, and also I inflate my stand here at the ATM also.
All right, okay.
Yeah, thank you.
All right, thank you, Dr. Arwin. So I'll invite our foreign faculty. So first, Dr. Nagamatsu. So I would like you to comment our second case by Dr. Dian regarding the use of many microcatheter with the special needs. So what do you think, Dr. Nagamatsu?
Yes, so anyway, the first of all, very, very congratulations. So it looks like a very, very complicated, but a cheap patient. Very nice. Very nice procedure. Yes, so basically the weighing the main devices like a guide wire and the microcatheter for the CT PCI. So anyway, so I can, and I think about the crusade parallel guide wire technique is there looks like a very beneficial for this CT PCI procedure, and especially the RCA. And so I have the one question, why did you choose XTA? And so I hear about your option, and if the failed RCA CT procedure from the antegrade, and you mentioned they're using the septal channel for the retrograde PCI procedure for the RCA. And what is their evidence for the using their septal? Thank you.
Thank you for the question, Sensei. And in this case, because the RCA has a very long and diffuse disease, so we really want to have a very good backup strategy for that. So that's why from this lesion, this patient had several collateral vessels actually through the circ in the epicardial, and then the distal LAD through the epicardial, and then through the septal. But because if something happened in epicardial collateral, it can had a very problematic issues such as tamponade and a lot of things. So we choose septal as our backup strategy. But during when we did this case from the unchoked wire escalation and with a good parallel wire technique, and the wire can go through the RV branch, and then from that we can go through the distal RCA, and thankfully we don't need to do a retrograde. I think that's all.
Okay, that's good. Okay, it's okay, Dr. Nagamatsu?
Sorry, we can't hear you.
And so anyway, so 8 years ago, and I went to your hospital. I remember.
That's right.
Anyway, so
reunion.
yeah. Thank you very much in this time. So anyway, so I will give the good information. And do you know J channel score? J channel score is for the estimating the difficulty of the collateral channel guide wire crossing. And please refer to this paper.
Okay, thank you. Thank you, Professor.
Welcome.
Okay, the last Asri maybe to commenting Arwin's case. So Asri, so what do you think? Do you use Coulot technique for this kind of situation, or DK crash because it's well fashioned today?
Congratulations. I think both cases are very tough and very well, nicely done. I think the angle of your LED in diagonal, I think favors either DK crush or Coulot, not TAP or T stenting. I think DK crush you can use for a lot of things. The thing about Coulot is, number one, I think both vessels should be of almost the same size. Because the size discrepancy, it can be quite difficult to do Coulot. I think that's the most important thing, and the angle. If it's more than 70 degrees, then it might not be feasible. What's interesting is I was caught off guard when you did your jail balloon technique, even at the branch of the diagonal. I'm just getting into jail balloon technique, and you did the third type of jail balloon technique. I remember there's a lecture by Dr. Fauzi from Bandung, and he presented, this is the more difficult Saito's version of jail balloon technique. I'll just use the uninflated balloon. The other thing is, what's interesting is you trap your wire in your diagonal and use that as an anchor. I usually take out my wire when I actually stand across, because I don't want my wire to be trapped between two stand struts, So basically, just like DK crush, when I do Coulot, when I put the second stand, I'll actually remove the wire of the first stand, so I won't. So it's interesting you use that. Only worry is sometimes the wire can get more trapped in your between two stand struts. But you use that as to anchor. That's interesting. And most of the time, it doesn't matter where you Coulot into, as long as you Coulot into the more angulated branch. That's the most important thing. And then proximally, you must leave enough to port. If you don't have enough to port, you'll end up sometimes crushing your carina and things like that, because the shortest balloon is 8 millimeters. Sometimes, if your left main is very big, you can actually extend your smaller balloons into that. You got a 5/0 left main. Sometimes the 3/0 balloon, if you just port proximally, will just hang into the left main. But you have to be careful. You have to take this into consideration. Otherwise, I think it's a case nicely done. Yep. Yeah.
Okay, thank you very much, Asri, for the nice comment. So sorry, Arwin, because our limited of time, because now is 5:30 Jakarta time. So I would like to summarize that today we learned about the use Crusade double lumen catheter. So like Dr. Nagamatsu mentioned us, it can be done, or it can be done in the sideband access, and also to crossing stand strut using stand boost, reverse wire, parallel technique, and then also for CTO. And also we also learned from Dr. Aspranga regarding the code technique, the philosophy, and then how to do it properly, and also balloon technique. So also we also learned from both of the case studies that it was amazing case, and then nice result, and then step by step we learned both of the cases. So by this, I think I conclude this session, and then I will thank you very much for all faculties Asri, Dr. Nagamatsu, and Dr. Aki, and Dr. Arwin, and of course Dr. Nahar and Dr. Ismail for the nice evening sessions. So I think that's all. So I would like to say thank you very much. And then we have continuing distance learning like this every 2 weeks. Now we have a line until 2021. So every 2 weeks we have welcome Asri if you want to join us. So it's a kind of busy session for us. So anyway, again, thank you very much for the Biocensus and Kadeka and then all the committees regarding the this event. So anyway, thank you very much. And again, happy Independence Day. Hopefully everybody stay safe and stay healthy for everybody. So I would like to say thank you very much. Bye-bye. Good afternoon and good evening.
Yeah.